Good morning, students. This is Charlotte Liggett. I'm recording this lecture for week 2 because there's the possibility that I will not be able to be with you. As I mentioned to some of you last week, or early part of this week, my mother is struggling with some health issues right now, and I may need to be in Illinois. So if you would pull up and have in front of you the PowerPoint for week 2 entitled Characteristics of the U.S. Healthcare System and Using Economics to Study Health Issues. That's what I will be going through these slides one by one and talking with you. And we may end up with 2 different videos, but you should be able to access them, and they actually ought to run simultaneously. So, as we talked a little bit last week, we talked about what are the determinants of health. What is it that we look at to determine health of a population, if you will? Well, on slide 3, I found a source that I found pretty interesting that seemed to ring true for me, and hopefully will with you too. So if we think about health and well-being as something that all of us strive towards, attaining that health and well-being, 30% is due to genetics, 40% is due to individual behavior, 20% due to social and environmental factors, and 10% is due to health care. So you can quickly begin to see, whoa, what's the what's the gap? What's the delta then between what's determining health and, as a society, where we are spending our money, which is in healthcare. So let's move on to slide number 4. And in slide number 4, I'm using some data from, I think, from this same source, or it might have been from the Kaiser Family Foundation. But if you look at the bottom of the slide first, we talk about health outcomes as being mortality, morbidity, life expectancy, healthcare expenditures. So how much are we spending on health, health status, functional limitations. And then if you look across the top, the titles of these different columns, we look at economic stability and how it contributes to health, neighborhood and physical environment, education, food, community and social context, and then again the healthcare system as a whole. I think as a society we have kind of grown up with the fact that the healthcare industry is going to be responsible for my health. Certainly as nurses, and then as human beings paying attention to a lot that's been in the literature in the last 10 years, we know that there are so many other factors that contribute to the health. And we are a part of that, but certainly not the totality. So just wanted to give you, again, access to some information. You can read through this slide at a later time and kind of begin to think about maybe your own life or your work in terms of, where is the interaction or where is the intersection happening for you relative to the social determinants of health. So a quote, which I like to start with a quote, is the prevailing mode of competition in American culture thus continues despite convincing evidence that it is damaging to physical, spiritual, emotional, and social health. Well, that's kind of an ouch, right? Because competition is something that we maybe pride ourselves on. Continuing with the quote, and what is the reaction of members of the helping professions? Are we creative agents of social change, or are we dispensers of Band-Aids to the injured and facilitators of adjustment to the way things are? This is a quote from a woman by the name of Vera Ellison. She wrote, it's an article, Competition, a Cultural Imperative. But I share it with you because it kind of speaks to some of the, it speaks to the heart of what some of us are trying to do in healthcare, what you all are trying to do in healthcare, and that is really help people be healthy. I think it also asks us some rhetorical questions, particularly the middle part of that, and what is the reaction of members of the helping profession? If we discover that competition, which I think leads to a lot of stress for people, and other things, is damaging to physical, spiritual, emotional, and social health, what are we doing about it? A rhetorical question. But moving on to slide 6, here are 3 questions that I will be posing on discussion board and asking you to complete. In healthcare decision making, who makes the choice? The physician, the patient, the provider, the payer. So just, give me a couple sentences about how you would answer that question. The second question, how do these choices impact marginal benefits and marginal cost? In other words, what makes the benefits go up and what makes these benefits go down? What does the role of choice have in, and we're going to talk later about marginal analysis and beginning to look at things from an incremental perspective. And then the third question, how do consumers impact the laws of supply and demand in healthcare? So as I mentioned earlier, I will post these questions on discussion board, and because the class is not meeting, I would ask that you go to discussion board, create a new thread, answer these 3 questions. And then I would also encourage you to go and read what your colleagues have written. That's a way for us to have an online class discussion. So moving on to slide number 7, we have a duck teaching other ducks how to speak duck, or it's called beginning duck. Again, my sense of humor, because all of us feel perhaps a little bit like we're trying to learn a new language, and we are. In this course, Economic Policy and Healthcare, we are trying to learn a new language. We're trying to get some concepts into our head that we haven't spent very much time thinking about. So I would invite you then to look at slide number 8, and this is a slide that helps us understand marginal analysis. So, and this is a little bit different than the slide that's in the book. So let me describe this slide, this graphic to you a little bit, and then I'll probably also turn to our book, our textbook by Henderson, and actually read the definition of marginal analysis. So on the y-axis, where we see the $sign at the head of the y-axis, it's talking about marginal benefits and marginal cost. So MSB stands for marginal benefits and MSC stands for marginal cost. And one of the things that happens in economics is we always compare one thing to another. Economists love to work with graphs, if you will, to explain how the economy works, how basic concepts in the economy work. So as we look at the x-axis, this is just talking about quantity. So it's a quantity from 0 to 100, and we see them labeling Q2, Q3, Q1. And then they've kind of, if you can see it on your slide, they've kind of highlighted this net benefit between actually Q2, sub 2, and Q3. So there's a point at which costs are low enough and the benefit remains high enough before the costs start to go up. And this is what one of the CFOs that I dearly loved working with, a woman by the name of Jeanette Wodolewicz, if we could hit the sweet spot. So the sweet spot, so let me see if I can translate this to you for in a healthcare or nursing unit perspective. So let's say we have a nursing unit and there's an average daily census, or that's projected an average daily census of 20. We might know through analysis that the break-even analysis, and on break-even analysis, the average daily census is maybe 17 for that unit. Maybe they can take all the way to 25 patients, but there's a break-even analysis at 17. In other words, you have less than 17 patients, you run the risk of losing money on that particular unit or for that particular service. On the other hand, we're projecting an average daily census of 20, but they could actually go to 25. Well, let's say this particular unit over a month's time hits an average daily census of 23. Well, we've just kind of hit the sweet spot, if you will, because we know that it's far enough above our break-even point, and that every additional patient or every additional procedure we're going to make money on that particular nursing unit. Now, what I've just described to you is kind of old world healthcare, because as we move into the arena of healthcare reform, there's times that we want the volume, but there's also times that we don't want the volume. And we've lived with this since the advent of DRGs in 1982. But back to marginal analysis. Marginal analysis just helps us understand that it's not an all or nothing proposition, that we have opportunity for incremental gains within a band. And sometimes that band is narrow and sometimes that band is a bit wider, if you will. Let me read out of Henderson, or draw your attention to the definition of marginal analysis in Henderson, because it is one of our 10 economic concepts that you're going to, some of you may have already started to use it, which is great. But here's what Henderson says about marginal analysis. Marginal analysis is the economic way of thinking about the optimal allocation of resources, i.e. the sweet spot. Choices are seldom made on an all or nothing basis. They are made at the margin. Decision makers weigh the trade-offs, a little more of one thing and a little less of another. In this environment, consideration is given to the incremental benefit and incremental cost of a decision. And that is what happens in the real world. We may have something that with lots of volume will bring some pretty strong financial benefits to a particular service or an organization, but that volume might not materialize. And then we have to back off and say, well, incrementally, what is happening? So it's really the concept of incremental change from one quantity to a different quantity, and then identifying financially what are the benefits or not. So we're going to move on and talk about 3 additional economic concepts: economic optimization, supply and demand, and competitive model. So economic optimization, I'm reading off of slide number 10, looking at slide 10. The basic economic problem, so there's 3 questions in any economic discussion. What do we produce? How do we produce it? And who gets it? And the how do we produce it here is, a bit more about the costs that go into it versus a clinical perspective. The two go hand in hand, but this is more about how do we produce it? What are the logistics and what are the resources needed to produce whatever it is that we're producing? So then, in terms of economic optimization, we could talk about marginal benefits. That's a change in total benefits resulting from one unit change in the level of output. We just looked at that on that graph of marginal analysis. Same thing with marginal cost. Change in total cost resulting from one unit change in level of output. So if you turn again in Henderson to a graph at figure 2.1, you'll see in Henderson has given us now this economic optimization. The top graph, again, the y-axis is benefit and cost, and the x-axis is units of medical care, pretty similar to what we just looked at on the previous slide. So with this, we see that the total benefits, if you start at 0, the total benefits rises pretty sharply. And then there's a point at which the total benefits continue, but before we get to the dotted line A, we see an intersection of total cost. Once total cost rises above total benefits, we have now moved ourselves away from economic optimization. So the principle here is that money wasted in the provision of unnecessary care cannot be used to further other important goals. I think we know this intuitively, but from an economic perspective, you now know that it works. It's an economic concept that we can provide unnecessary care, and that does not contribute to important goals. And so I think one of the ways the healthcare industry is trying to deal with this right now is the advent of palliative care. Palliative care, if you are familiar with palliative care works at a reduction of suffering for the patient, which is an altruistic, in my mind, is an altruistic goal. But in the process, then the industry is saying no to perhaps some high-end or high-dollar diagnostic procedures, even treatment procedures. Instead, the goal is to relieve suffering for the patient, get them as comfortable, get them back home, get them into their own home environment. So palliative care is an example of how we in the healthcare industry are working towards this economic optimization. Well, let's move on to supply and demand, and I may have to shut this portion of our conversation off because I don't want to let the video get so long that part of it is dropped for you. But I think we have time for supply and demand. So supply and demand through the years and continues to be a powerful tool in predicting future behavior. Factors that influence consumer purchasing are, of course, the price of the commodity, the price of related commodities, the number of people desiring the commodity, and then consumer income, preference, and expectations. So there's a lot that influences consumer purchasing. How much something's going to cost, how much a substitute item might cost, the number of people desiring the commodity. You know, when iPhone 6 came out, people were standing in line waiting for iPhone 6. So that's an indication of, high desire. But then we also want to factor in the consumer income, preferences, and expectations. What I'm paying for, I need to know that it matches the quality or the value that I'm receiving. So law of demand is actually an inverse relationship between the amount of a commodity that a person will purchase and the sacrifice that must be made to obtain it. So an example in healthcare is these high deductible health plans. They impact consumers' choice for both diagnostic and preventative care. In other words, demand or utilization of a diagnostic exam is dependent on the consumer's willingness to sacrifice something to pay for that. So law of demand, we always want to think about that as an inverse relationship. The demand is going to, it won't go up directly. It's an inverse relationship related to how much the consumer is willing to pay. So, demand might be the denominator, or demand would be the numerator, and the denominator is what the consumers are willing to sacrifice for that. Law of supply, on the other hand, is a direct relationship. And the law of supply is between the amount of commodity that a producer will make available and the reward that is received. So the producer is going to produce more if they're making money on it. An example in healthcare right now is the preponderance of ambulatory surgery centers versus drug and substance abuse centers. Now, we all know that drug abuse, alcohol abuse, we have a lot of that in our society, but it doesn't pay very well for a variety of factors. I'm not getting into that. On the other hand, ambulatory surgery centers, yes, there's a demand, but the producers get paid a whole lot more for ambulatory surgery centers. Some of these ambulatory surgery centers are owned by physicians, some are owned by hospitals, some are joint ventures between a hospital and a physician. So in terms of what society actually needs, one could make a case for the fact that we need a lot more drug and substance abuse centers. But what comes back to the producer, the reward that comes back to the producer, is not anywhere comparable to what they can make in an ambulatory surgery center. So that's law of demand is an inverse relationship related to what the consumer is willing to sacrifice. Law of supply is a direct relationship related to the reward coming back to the producer. One more slide about on supply and demand. So supply and demand actually impact prices and price elasticity. Changes in price affect demand in two ways. Consumers may choose to spend dollars on a different commodity. Consumers' overall level of satisfaction is reduced. The healthcare examples is brand drug versus generic drug, or cabbages versus angioplasty. There's price changes and price elasticity. Price elasticity depends primarily on the consumer's ability to find suitable substitutes. So a healthcare example is there's no appreciable difference between St. Elizabeth and Bryan Health from a consumer perspective. Now some of you who might be hearing that would say, well, I'm part of CHI Health, so St. Elizabeth is better. Others might say, no, I trained at Bryan Health, or I'm part of a consortium that's working with Bryan Health, and Bryan Health is better. In actuality, from the consumer's perspective, they are very similar, and that's a common issue for us in healthcare. So the final point that I want you to understand about prices and price elasticity is that there are factors that affect the consumer's ease of substitution, and there's two major ones and then some others. So the percent of the consumer's income that will be spent. So price elasticity, Coke, for instance, is like, well, if I don't like Coke, I can drink Pepsi, or if I don't like Coke, maybe I can drink a Mountain Dew. So on the other hand, so there's not much price elasticity between Coke and Mountain Dew. Maybe they're made by the same producer. I can't remember that. But that is opposed to like buying a new car or making a purchase on a home that you're going to live in. So the percent of a consumer's income that will be spent impacts price elasticity. So home prices there's a wide range of home prices. So price elasticity can move up and down, again, related to a variety of factors in the economy. The other factor affecting consumers' ease of substitution is urgency of the decision. And we see that in healthcare all the time, right? I mean, people have this, you come into the ER, physician diagnoses you, the physician is saying you need to have this taken care of right away. You may be in pain, or your family member may be in pain or uncomfortable, or it's just clear it needs to be handled. So the urgency of the decision also comes into play. That's why we don't have much price elasticity in healthcare. When we're providing the same product, the same service between different producers. So I'm through slide 12, and I'm going to stop there because I'm worried about this video time running out, but I will pick up again in just a minute.